Hello, my name is Jim Seibold. I'm the president of Scleroderma Research Consultants in South Carolina in the United States. And I'm quite pleased to speak with you today and very much appreciate the invitation by Tafazul Mahmood. I've been rather impressed with the growth of academic rheumatology in Pakistan and very delighted to be able to participate in this conference. Uh, Tafazul has asked me to discuss interleukin 6 and its role in scleroderma, and more specifically to address the question if tocilizumab is a potential treatment modality. Now, here's a slide that summarizes the complex pathogenesis of scleroderma. This was developed about a decade ago, led by Michael Whitfield, who's been a pioneer in genetic research in scleroderma. And I show this recognizing that it's a very busy slide, but to sort of emphasize the point that scleroderma is both clinically heterogeneous, but it's also pathophysiologically heterogeneous. And we recognize that if we come up with a cohesive hypothesis to explain pathogenesis, we're going to have to deal with the mechanisms of vascular injury, then the interplay of vascular injury with the immune system, including immune activation, and then the cascade of profibrotic and proproliferative cytokines that lead to the pathway of tissue fibrosis. Now, we know that if we treat systemic sclerosis extremely aggressively, for example, with stem cell transplantation, follow immunoablation, that we can actually change the natural history of the disease. The question now becomes, can we find some therapy that is less toxic, less invasive, and by definition, more targeted that can mimic those same clinical effects? Now, in keeping with this theme of heterogeneity of disease, we now recognize that scleroderma patients have a very complex gene array or genomic expression with well over 700 genes that are expressed in variable levels in different stages of disease. And we recognize that there's a genotype associated with the phenotype of diffuse scleroderma, and then one that is associated with limited scleroderma. And then we also recognize that even within the context of diffuse scleroderma, we have a fibroproliferative phenotype, a pro-inflammatory immunologically activated phenotype, and in some of the cases, particularly in later stages, a normal genotype. Now, the reason I bring that up, again, back to this concept of heterogeneity, is that we recognize now in diffuse scleroderma that the disease, just like it worsens early on, tends to plateau, and in many patients tend to sort of stabilize or improve later in disease. We see parallels in terms of what's going on with gene expression. So here we're looking at a study that came out of Monique Hinchcliffe and Michael Whitfield's lab again, recognizing that within scleroderma genotyping, you can have a normal, like a gene array, a pro-inflammatory gene array, and a fibroproliferative gene array. And in fact, that predicts response to therapy. So that in those patients that express an inflammatory gene array, abatacept and mycophenolate mofetil were both found to be relatively effective in that population. Whereas in the population that was expressing mainly evidence of an activated TGF-beta PDGF pathway, those were the patients that responded to lanadelumab. So I don't think we're quite there yet, but we're close to the stage where the genomic and proteomic characterization of your patient will actually ultimately lead to your choice of therapy. And then finally, if you look at gene clusters that are expressed in scleroderma, we see that there are gene clusters that are associated with transforming growth factor beta and extracellular matrix accumulation. There are gene clusters that are associated with type 1 interferon biology. And then finally, and most importantly, for the purposes of this lecture, there are a large percentage of patients that express activation of the M2 macrophage. And as we all know, the tissue macrophage is a rich source of interleukin 6, which brings us to the primary subject of this lecture. So, just to sort of, I'm painting in broad strokes here, but to try to lay sort of the background for consideration of therapy, because I think the punchline that will come out of this talk is that yes, there is a role for tocilizumab in scleroderma, but it very much, uh, use of a targeted therapy like this very much depends on appropriate patient selection. So, as we unravel the complex biology of scleroderma, one could come up with a rather extensive list of specific targets it would be scientifically plausible or rational to attack. And in that list is interleukin 6, but that doesn't necessarily assign it a greater priority than lysophosphatidic acid or the PPAR gamma pathway or interleukin 4 and 13. Uh, but at least we now have data to evaluate this specific area. So let's consider the biology of interleukin 6. It's produced mainly by macrophages, but also by osteoclasts, adipocytes, and certain perivascular cells. One of its roles, particularly macrophage-derived interleukin 6, induces pattern recognition receptors, the classic example of which would be C-reactive protein. So in general, macrophage-derived interleukin 6 causes an increase in acute phase reactants, an increase in B cell expression, and a diminution in T regulatory cells. So is there a translational literature that links interleukin 6 and, for that matter, C-reactive protein to clinical outcomes in scleroderma? And the answer is yes, actually, rather robust data. Elevated interleukin 6 levels predict the severity of skin involvement uh, 3 years after scleroderma onset, and they also predict early mortality. Elevated IL-6 levels are associated with a higher incidence of progressive pulmonary decline and early mortality in scleroderma interstitial lung disease patients. And overall, elevated CRP levels in early scleroderma predict ILD progression, overall survival, and have strong correlations with the severity of skin, lung, and joint manifestations. The role of interleukin 6 is particularly important in consideration of interstitial lung disease. In a validation cohort of 212 patients with well-characterized interstitial lung disease, interleukin 6 levels above 7.67, that was the cut point in the study, was predictive of a decline in forced vital capacity, a decline in diffusive capacity, death within the first 30 months of follow-up, and functional decline or death within the first year in patients with relatively mild interstitial lung disease, specifically patients that entered the trial with FVCs greater than 70%. Okay, so these data suggest that IL-6 is particularly important in early disease and may be a more critical biological element in pathogenesis of worsening of early disease, although there does appear to be maybe a proband of patients with later, more severe disease where the interleukin 6 biology is less relevant. Well, anyway, against this data, this makes the study of tocilizumab quite relevant and a noble undertaking. So, virtually both of the major studies of tocilizumab were led by Dinesh Khanna, who's currently the director of the scleroderma program at the University of Michigan. And virtually all of the data that I'm going to show here are from studies that Dinesh led, although they were multi-center international trials. We started out with a phase 2 trial where the primary endpoint was the modified Rodnan skin score at 24 weeks. And then there was a follow-up phase to 48 weeks looking at the secondary endpoint. And what we're seeing here, the blue line are the patients that were receiving tocilizumab subcutaneously on a once weekly basis versus the patients that were receiving placebo. And there were about 40 patients in each group. And what one can see here is typical of virtually all of the studies we do where modified Rodnan skin score has been chosen as the primary endpoint, which is there was some level of improvement on placebo. And at no stage during this 48 weeks of follow-up did this achieve statistical significance. So this was basically a negative trial because the primary outcome measure of modified Rodnan skin score failed to achieve clinically significant difference. However, there were other data in this trial, and one of the prominent secondary outcome measures was the change of percent predicted forced vital capacity. And here we're showing the data out to week 48. And what one can see here is that the whole line is shifted to the right in the tocilizumab treated group, meaning there were less patients had no decline, far less patients that declined in the 0 to 10%, and even far less patients that had greater than 10% decline in FVC. So it suggested across the whole range of measurements here based on entry FVC that IL-6 had a protective effect in terms of preventing further decline in forced vital capacity. Now, mind you, you have to look at data like this with a certain level of skepticism because these patients were selected for this trial not because of their lung disease, but they were selected based on the extent of their skin involvement and their duration of disease. So mind you, this was primarily a skin trial, but with forced vital capacity as an important follow-up measure. That led to the performance of a larger phase 3 trial of tocilizumab. Again, there was a screening period of about 40 days. There was a 48-week double-blind treatment period followed with an open-label treatment period. And again, the treatment was a 1-to-1 randomization of tocilizumab subcutaneous weekly versus placebo. There were 210 adult scleroderma patients that participated in this international trial. There was an escape wing or rescue therapy, if you will, at week 16 for patients that had worsened their modified Rodnan skin score or developed other important complications. But the critical thing to recognize is in the white box down at the bottom. Again, the primary outcome measure was chosen as the change from baseline in the modified Rodnan skin score. And the rationale here, why would you do a follow-up study when you've had a negative phase 2? It was a simple statistical determination that if you took the difference between tocilizumab and placebo in the phase 2 trial and increased the sample size to increase the power of the study, then it would have achieved statistical significance. So this was actually a reasonable approach. This was a more than doubling of the study size and based on statistical calculations that were derived from the phase 2 results. The key secondary endpoint was the change from baseline in the percent predicted FVC, the time to treatment failure, and then, of course, patient-reported outcomes. Here are the key inclusion-exclusion criteria. Scleroderma by ACR-ULAR criteria, less than 5 years of disease from the first non-Raynaud manifestation, a modified Rodnan skin score between 10 and 35, evidence of active disease, and then at least some level of evidence that they were at the immunoinflammatory stage that we mentioned before. Gene arrays were not done, but this included either an elevated C-reactive protein or an elevated sedimentation rate or an elevated platelet count. No competing immunosuppressive therapies were permitted. Here are the demographics of the study. This is rather typical for virtually all of the larger trials we've done in scleroderma. They were dominantly female. They were basically in their late 40s. The duration of disease, even though it permitted out to 5 years, was more typically around 2 years. The mean modified Rodnan skin score was about 20. Again, since these patients were not recruited for their lung involvement, their lung was actually relatively mild. They had forced vital capacities in the low 80s, diffusive capacity in the mid 70s. This incidentally mimics virtually every trial we've done in scleroderma lung disease. Both the American NIH-sponsored studies of cyclophosphamide and mycophenolate, but also the recent big trial with nintedanib. This looks very similar to both in terms of patient demographics and pulmonary function to these large trials. And please note that about half of these patients had positive anti-topoisomerase antibody. And the mean C-reactive protein was in the order of 7 or so, clearly elevated in this population. Well, again, this was a negative study in terms of skin, and it was largely a negative study in terms of skin because the placebo group tended to improve. But the first secondary outcome measure, which was change from baseline in percent predicted FVC at week 48, was dramatically positive in favor of tocilizumab. And you can see that in the graph on the left part of the slide. The red line is the change from baseline in FVC in the tocilizumab treated group, and the blue line is the placebo behavior. And you can see there was a rather remarkable separation here. And this was highly statistically significant. And the difference between the treatment arms was around 6.4% FVC. I think anyone would agree that that's a clinically notable, certainly clinically important benefit. And again, if we go back to the same distribution of change across the whole range of pulmonary function changes, both from stability down through a significant worsening, at all levels of change, it favored tocilizumab over placebo. The way things are projecting here, I can't see the relevant part of the slide. Elizabeth, is it possible to unmask the right column somehow or to minimize? There we go. Okay. My apologies for very busy slides like this, but this, I think, is the critical essence of what we've shown you, because it gets back to this heterogeneity and the importance of precise patient selection. This was not an across-the-board abnormality, and this is trying to break down the predictors of response to tocilizumab. So it was borderline statistically significant in females, but highly significant in males. It was highly significant in patients who had less than 2 years of disease duration, but the differences in pulmonary functions were not significant in patients after 2 years. It was statistically significantly related to levels of inflammatory change. You could see there was a correlation with elevated platelet count, a very strong relationship with C-reactive protein levels above 6, a very strong relationship with anti-SCL70 or topoisomerase 1 positivity, a strong relationship to lower modified Rodnan skin scores, less than 25, but not so much for worse disease. So we're looking at something that describes a male population with evidence of active inflammatory change as measured by C-reactive protein, but also other acute phase reactants that tended to be earlier and had more mild skin involvement. My apologies, but for some reason I'm not able to advance the slide now. Oh, here we go. So to break this down a little bit further, I have a series of graphs that demonstrate the separations here. And in each case, there are 4 lines that separate treatment, tocilizumab versus placebo, and then positivity or negativity in the feature that we're looking at. So here, in all cases, the solid red line are the placebo patients that lack the feature, and the solid blue line are the treated patients that have the feature. So here we're seeing if you're anti-topoisomerase 1 positive on drug, your FVC is remarkably stable, but of the group that did the worst were the placebo-treated patients that were anti-topoisomerase positive. Okay, and then on the right-hand side, we're looking at the relationship to elevation of C-reactive protein And again, you can see that if you had an elevated C-reactive protein and received drug, you did significantly better than the placebo group that had an elevated C-reactive protein. What if we put these two features together of a positive anti-SCL70 and C-reactive protein at 48 weeks? You can see that on tocilizumab, um, both groups were better than the placebo, but the group that did the worst were those patients receiving placebo that were anti-topoisomerase 1 positive and had an elevated C-reactive protein. And then if you look at disease duration, the early patients did remarkably well. The separation between drug and placebo was much less notable in patients with greater than 2 years disease. So the pulmonary function, that should be enough. The U.S. Food and Drug Administration approved nintedanib as a therapy for scleroderma interstitial lung disease in 2019 based on a change in forced vital capacity over a year of follow-up, in spite of the fact that there were no effects on skin or patient-reported outcomes. And the key message here is that the regulatory agencies accept a delta forced vital capacity as a robust surrogate for survival. That's clearly true in other interstitial lung diseases like idiopathic pulmonary fibrosis, and perhaps a little bit less well fleshed out with data in scleroderma, but nonetheless a fundamentally good concept. But it's not just change in forced vital capacity that we saw in these studies of tocilizumab. Here we're looking at serial HRCT studies. Patient number 1103 and patient number 1053 were both treated with placebo. And what one can see is actually their HRCTs tended to worsen during 48 weeks of follow-up. And that's in contrast to patient number 1035 and 1149 on the right-hand side, where you can see that there was a marked diminution in the areas of radiopacity on HRCT. Really, maybe what you're seeing here is the same basic pattern of involvement, the areas where the disease was, but you can easily appreciate in both instances how there was a diminution in HRCT findings. So I think this has led to sort of a total re-examination of how we should be thinking of and approaching interstitial lung disease. I think the basic first concept is pulmonary function tests alone are not enough to screen for it. You need to do an HRCT because many patients have subclinical disease that is positive on HRCT but not recognized on pulmonary function tests. Then the question is, once you've decided that there's a presence of ILD, is this appropriate for drug therapy? And the answer there, if it's yes, is can you treat the underlying autoimmune disease? And that would be with immunomodulatory therapy. But if that patient is progressive, then you might need to consider a different immunotherapy or adding an antifibrotic therapy. So let's see if we can't flesh that out a little bit more. Oh, and should always mention that we're critically lacking good data on combination therapy right now. So back to yet another view of the pathogenesis of tissue damage in scleroderma. This is what's applicable just to the lung, but the focus of the talk here is on macrophage biology and interleukin-6. And we do have richly present within the lung and basically well distributed through the epidermal mesenchymal junction, which is the site of fibrosis. Here, the type 2 alveolar macrophage, which is recognized to be a rich source of interleukin-6. But it's not just that we see these sorts of effects in tocilizumab. I mean, here's the pilot trial of around 90 patients, half on drug, half on placebo, with abatacept, which again, we see that abatacept in patients with less than 3 years disease duration that are naive to all of the therapies experience less decline in forced vital capacity than the group receiving placebo. We've also had good initial studies of rituximab. And here we're looking at a trial that compared intravenous monthly cyclophosphamide with rituximab for the treatment of early diffuse scleroderma with interstitial lung disease. And what one can see here is that at 6 months, the rituximab group had actually gained about 6% uh, predicted FVC, whereas the cyclophosphamide group had basically remained stable. So it isn't just tocilizumab, but it's the concept that there's clearly an immunologically active stage of scleroderma lung disease that seems to be responsive to treatment uh, with abatacept, rituximab, tocilizumab, mycophenolate mofetil, and cyclophosphamide. So if you take these data and go back to the whole approach to interstitial lung disease on HRCT, if it's very mild with well-preserved pulmonary function, a group of patients that is recognized to be at very low risk of progression, probably the best thing to do with those patients is just follow them up closely. And if you see evidence of progression, consider treatment. However, if you have a high risk phenotype, early diffuse scleroderma that has a positive anti-SEL70, or early diffuse scleroderma that has an elevated C-reactive protein or other evidence of acute inflammatory reaction, now we have options. One option prominently supported by the data that we've discussed in this lecture would be tocilizumab. But if this is not available, mycophenolate mofetil, or intravenous cyclophosphamide or oral cyclophosphamide are all considered valid therapies supported by high-level randomized controlled trials. If on initial presentation your patient has clinical ILD, but their skin seems to be quiet and their musculoskeletal features seem to be quiet, but you really need to sort of try to put this all in context. How active are these, and are there other benefits that are non-pulmonary that you might be able to pick up with the therapy? So let's say if the skin were active, if the musculoskeletal components were active, you might treat that patient initially with mycophenolate. If those features were quiescent, then I would treat that patient initially with an antifibrotic therapy like nintedanib. So again, we're starting to see cut points here where, again, the focus should be on the lung. It's the leading cause of death, but the choice of therapy is going to be highly influenced by the clinical context in which the interstitial lung disease is encountered. So active disease, mycophenolate, cyclophosphamide, rituximab, maybe upfront combination therapy. We've shown the data with tocilizumab, excellent for lung, but not effective for skin and not effective for patient-reported outcomes. So it deserves to be in the mix, but your expectations of therapy should probably be focused on the lung outcomes. Then if your patient has failed your initial approach to therapy, you've still got options here. You can flip to a different immunosuppressant between cyclophosphamide and mycophenolate, or consider adding rituximab or adding tocilizumab or adding nintedanib if you elected not to go with an antifibrotic therapy. And then ultimately, these are the patients that you might want to consider for hematopoietic stem cell transplantation or even lung transplant. So I thank you for your attention. I would just sort of like to take you through the high points of this lecture. It's really focused on scleroderma interstitial lung disease, and it should be, because that has evolved to be the leading cause of both morbidity and mortality in scleroderma. The current management of scleroderma interstitial lung disease is focused on targeting the underlying systemic sclerosis with immunomodulatory therapy, But biologically targeted therapies, including tocilizumab, have shown a great deal of promise in early active lung disease. Uh, we have an antifibrotic therapy that's now licensed in nintedanib. Uh, we know from their trials that a combination of nintedanib and mycophenolate was better than either agent used alone, but we still need additional trials of combination therapies uh, that address different aspects of pathogenesis and different stages of the clinical disease. So the question posed by this lecture, does tocilizumab have a role in scleroderma? The answer is absolutely, uh, but its role looks to be relatively restricted to early lung disease, maybe more so in men than women, uh, who are topoisomerase 1 positive and have evidence of an acute phase response. Uh, like all therapies in scleroderma, I don't think you can make a generalizable statement about applicability across the full spectrum of disease. But I think if we recognize the challenge of clinical and biologic heterogeneity, along with our increased understanding of pathogenesis, we can begin to identify those segments of the population that should respond to very targeted approaches to therapy. And tocilizumab is definitely amongst your options there. I thank you for your attention.